international experience in advanced endodontics. After completing his MDS in 2005, he has been associated with the Kuwait National Guard and Ministry of Health since 2009, where he continues to serve with distinction. Dr. Saqib has presented at international platforms in Dubai and Italy with expertise spanning advanced endodontics, lasers, aesthetics, and conscious sedation. His long-standing commitment to clinical excellence and education makes him a respected figure in the global dental fraternity. Please join me in welcoming Dr. Inamdar Saqib Ahmed.
No, it's fine.
Sir, you have 15 minutes for the presentation.
Yeah. Good afternoon, everyone. It's such a pleasure to be back home. And I would like to begin the presentation with my sincere respect to my professor, Dr. Suresh Chandra sir, and Krishna Nayak sir, and Priya ma'am, who are no more with us. May they rest in peace. And my sincere gratitude to all my teachers, Mitra ma'am, Moksha ma'am, my guide, all my seniors and juniors. So with this, I'd like to begin the presentation. And before starting the presentation, I'd just like to say that this is an insight and an introduction, because this itself is going to cover a vast symposium. So I'm going to try my best to introduce it to you in as brief as possible. And in the audience, even if a few people get interested in it and start reading more about it and finally incorporate it into clinical practice, it will be 15 minutes worthwhile. So with this, I would like to say that when I'm practicing clinically and when I'm reading academically, as Mitra ma'am always used to say, that it is an amalgamation of academics into clinical practice. When we are reading something, it's going to be important only if we can translate it to the patient and get benefit out of it. The first thing is that, unfortunately, in endodontic treatment, whether it's postgraduate students or whether it's clinicians, it's a race. Who can finish faster? But I feel that if we give the due time that is needed to complete an endodontic case, and it gives service for 5 or 10 years more, it's that extra 15-20 minutes well spent. Now, periapical lesions, whether they are acute lesions which do not manifest on the radiograph or chronic lesions which do manifest on the radiograph, it is extremely important for us to know that good conventional root canal treatment is definitely going to heal it. So why use lasers? Lasers actually helps us to expedite this process. It heals faster and it heals better. We get good clinical success and long-term clinical success. Now there are some concepts which have changed quite a while back. I'm just going to rush through it. We all know about it, but when we are doing endodontic treatment, we don't give the amount of importance they need. The first concept was way back in 2005 when I finished my postgrad. So always used to tell us that cleaning and shaping is transformed into shaping and cleaning, which is so very true. Unless we shape the root canal system, or now known as the pulp space, how are we going to disinfect it? So always remember, good shaping is going to lead to good cleaning, and that will give rise to better clinical success. The second concept is that we normally visualize the root canal as a root canal system that is like a tube, a continuous tube. But what we fail to understand that it is an extremely irregular space. So we were always told that instead of saying root canal treatment, it's better to call it pulp space therapy, because we are going to disinfect a space and not a tube. It's easier to disinfect a tube, but very difficult to go into the intricacies of the internal anatomy of the tooth and disinfect it. Then there are few concepts which have stood the test of time. For example, like how Dr. Anand just mentioned, that isolation is extremely important and should not be compromised. Whenever possible, rubber dam isolation is mandatory, and the use of sodium hypochlorite as one of the primary disinfectants for as an organic solvent has still it is still the ideal irrigant of choice. Now, when I'm talking about sodium hypochlorite standing the test of time and still being used as the ideal primary irrigant, I mean to say that we have to give its due importance when we are treating cases. For example, the concentration, different studies have been done, 1.5%, 3%, 5.25%, even 6%. But we should know that the maximum amount of academic literature points towards a concentration of 5.25%. And the amount of, the copious amount of sodium hypochlorite for the amount of time it is in contact with the tooth structure. This is what I mentioned even earlier, that give endodontic treatment its due time. Take time to irrigate well and finish correctly. Then we come to various nickel titanium instruments. I have tried my best not to include any companies or manufacturers so that it becomes more scientifically oriented. Remember, we are taught about rake angle, positive, negative. Just to be very brief, use any manufacturer's rotary instruments, but decide for yourself. A positive rake angle will cut more, a negative will scrape more, but a positive is very aggressive and can lead to iatrogenic problems, and therefore most manufacturers in their research and development keep it either negative or slightly neutral. Why retrieve a broken file when we can prevent it? Remember, any system which you use, please establish a proper glide path, at least a loose 10K file before entering inside with any rotary instrument. Most manufacturers even give us a glide path, a pathfinder, but I feel that anything that rotates 360 degrees before it is entered into the pulp space should always have a pre-made glide path with a hand instrument to give it its due efficiency and prevent breakage. Irrigation protocol, different people have got different irrigation protocols, but just remember one important thing, try not to mix them. So you can use sodium hypochlorite, intermittently saline, and then 17% EDTA, so that you get optimal results and less mixture. One important thing is the final irrigant should always be 17% EDTA with saline. Now, I just mentioned all this because healing of chronic periapical lesions is possible with all this by itself. It's going to take time, and the healing may be very slow, not very complete. But with lasers, it is extremely fast and predictable. Now, when we are using a laser, for us, it is extremely important, just like irrigation, that the shaping of the root canal system or the pulp space has to be extremely meticulous. So what I mean by meticulous is that the fiber optic tip of the laser should come at least within 3 millimeters of the vicinity of the periapical foramen, that is 3 millimeters short of the working length. Now, how much do we enlarge? This is a question which we all contemplate. But if the canal is too narrow, I feel that at least to a 0425, and if it's a medium-sized canal, at least to a 0625 or a 0430 or 0630. Now, why am let us take the lowest level range. That is a 2504 or a 2506. If we see that the tip diameter at 3 millimeters for a 06 taper instrument is 0.43, and the irrigant tip is around, for a 28 gauge needle is around 0.36 millimeters. Now, why am I stressing on this? Because when you are doing a laser disinfection, or you are irrigating and disinfecting with sodium hypochlorite, it is extremely important for us to be passive and not active. If the needle is binding at that 3 millimeter point, the debris and the solution is going to be pushed forward rather than come outward. So the needle should be passively fitting at 3 millimeter level, or else the bacteria will be laughing their way out. Because irrigation, if it is done just superficially, is not going to be beneficial for long-term success of clinical therapy. Now we come to the main part of the presentation, and this I'm going to just try to introduce it to you. In short, we as dentists work with dental lasers in the infrared spectrum. So we have the near infrared spectrum, the middle, and the far. Now the far end, that is 10,600 nanometers, is for the surgeons, excessively cut and slash. But for endodontics and periodontics and other soft tissues, we concentrate on near infrared or mid infrared. What I mean by near infrared is the diode lasers, which we call them routinely, 660 nanometers to 810 nanometers. And the mid-infrared range, it can range between 2000 to 3000 or even 1500 to 3000 nanometers. Now the importance of this near and mid-infrared range is that we use both for healing of endodontic periapical resistant chronic lesions. There are two types. One is during endodontic therapy, and the second is after completion of endodontic therapy. Now, during endodontic therapy, it can be done again in two ways. One is with the irrigant inside the pulp space, and one is when it is a dry canal. So I'll just explain it very fast. You irrigate, and then you can either place the probe of the laser tip 3 millimeters short of the working length and activate it. This was used extensively before. Unfortunately, they found out that the patients, they had good long-term healing, but unfortunately, they had post-operative pain, probably because the irrigant was agitated so much that it got pushed out a little bit. So they modified it into pips and sweeps, that is the ultra short and very short shock waves which are given through the irrigant, not inside the pulp space but just at the orifice. This prevented extrusion of the irrigant, and it also helped in the tsunami effect inside, that is cavitation and acoustic streaming. It formed bubbles and engulfed the debris like phagocytosis and pushed it outwards, giving a very clean and a disinfected pulp space. Now, this is during the endodontic treatment. Now, what after we have finished our obturation? The canal is dry and there is no weeping canal. The paper points are coming out dry till the working length. Our job is done. We don't need to wait for the lesion to completely heal. We will obturate if the canal is completely dry and the patient is clinically asymptomatic. So now, what do we do after finishing endodontic therapy? We give something known as previously low-level laser therapy. It was called as LLLT. Present day, it's known as photobiomodulation. So most of my friends or my seniors who are wishing to buy a laser unit, normally we have a tendency of asking how high the laser can go. Unfortunately, that's not true. We should ask how low the laser can go. And the advantage of this is you can use it both for photobiomodulation as well as endodontic therapy. So at 660 nanometers to 810 nanometers, the diode lasers activate the cell. The activation is threefold. One, intracellular. It targets the mitochondria and releases reactive oxygen species and ATP. This help in the cell performance and activate the healing mechanism. The second is analgesia. There are opsonine receptors on the cell membrane which transmit impulses. They are blocked, and post-operatively, long-term, the patient has got analgesic benefit. So there is very, very, very minimal post-operative discomfort. And the last is extracellular mechanism of triggering. It triggers transforming growth factor beta. And this helps the totipotent undifferentiated mesenchymal cells to transform into the respective cell, maybe an osteoblast or a fibroblast, and gives good, accurate clinical healing. With this being said, we will see how this translated into clinical practice. We carried out low-level laser therapy or photobiomodulation for 8 weeks for all patients, and intracanal disinfection with erbium chromium laser, that is with yttrium, scandium, gallium garnet, commonly known as water lace system. Now, 2 types of lasers were used, 2780 nanometers and 2940 nanometers. So it can either be an erbium laser or erbium chromium laser. Both lasers were used simultaneously during root canal disinfection, and post-root endodontic therapy, the low-level laser therapy, that is photobiomodulation, at 610 nanometers. This was used standard for all the cases. Now the healing, which will be shown in the subsequent slides, some healed at 8 weeks, some healed at 8 months. So it depends on the healing capacity of the patient and also on the amount and how extensive the periapical lesion is. So we are just going to go through the cases. All have been managed as has been explained earlier. Now, this particular case had, you can see that there is a post in one of the distal roots. We did a CBCT, like how ma'am already explained in the first lecture. It is an extremely important tool in managing and planning of treatment. Though the post was in the distal canal, the mesial root was fractured, and it had to be extracted because it was a vertical fracture. And endodontic therapy was carried out for the adjacent tooth, and later on an implant was planned for the missing tooth. But the implantologist, when he went in after 3 months, the healing was excellent, and the prognosis of the implant also improved. So lasers can be used in multiple fields of dentistry, which will be emphasized by Dr. Sunil in the next lecture. And here the canine is obturated completely with MTA, putty MTA, which is pre-mixed. All the cases were done on patients between 35 to 50 years. And most of the cases were traumatic injuries of the teeth, which were dormant for a long time and had turned into a phoenix abscess. And this is one of very challenging cases which was done. Patient had come with grade 3 mobility and was definitely somehow going to lose it. But the patient was very patient, and the patient wanted to save his teeth, and he was ready to take the risk. And as I told earlier, some cases took 8 weeks to heal and some 8 months. So this was the 8-month case. So everybody has got a comfort zone. Try to think outside the comfort zone. Try to add an addition to your conventional practice to get good clinical results and give good clinical expertise to the patients, and that would make all the difference. Thank you.
Thank you, Dr. Saqib, for presenting clinically relevant cases and also revisiting the fundamentals of pulse-based therapy. Any questions from the audience? Would the panelists like to add something? Thank you, sir.
Thank you very much. Have a nice day.
We have the next lecture, a continuation on the topic of lasers from Dr. Sunil Erali.
Dr. Sunil Erali has completed his BDS in 2002 and MDS in 2005 from this esteemed institution. He was a former professor and head at Malabar Dental College. Dr. Sunil has been an invited speaker at numerous international